So as I mentioned, this is our third episode in our current series, and our current series is on clinical registries. Clinical registries play an important role in improving healthcare by collecting and analysing patient outcomes. They help clinicians and services understand where care varies, compare performance, and use those insights to improve care over time. And that's why clinical registries are a key focus within the CAH's priority focus area on data-driven clinical decision-making. This reflects our commitment to improving how clinical registries are developed, connected, and used across South Australia. As I said, this is our third episode, and clinical registries are helping health systems to learn and improve care, not just report outcomes. It explores how data platforms such as ROSA assess the safety and quality of care for older Australians, and how clinical quality registries support quality improvement in critical care settings. As I said, we have two wonderful speakers joining us today. Professor Maria Inacio is the Director of the Registry of Senior Australians, or ROSA, at Flinders University and SAMRI, and is a leading epidemiologist specialising in population health surveillance and data-driven healthcare improvement. She has extensive experience developing and using large-scale health registries, including over a decade working with Kaiser Permanente in the United States. I'd also like to introduce Associate Professor Paul Secombe, who's an intensive care consultant at the Queen Elizabeth Hospital and a clinical lead for the ANZIC Centre for Outcome Resource Evaluation Adult Patient Database. That's a long one. His work focuses on improving the outcomes for critically ill and vulnerable populations using the ICU data to support quality improvement and national benchmarking across Australia and New Zealand. So with that, with no further ado from me, I'd love to pass over to Professor Maria.
Thank you so much for the introduction and the opportunity to come and share with you some work of the Registry of Senior Australians my team and I are doing here at SAMRI and Flinders University. I want to acknowledge the Gunna people as traditional custodians of the Adelaide region before I get started, where I'm based, and also the Gunna people's cultural, spiritual, physical, and emotional connection to the land, and to honor and pay my respects to the Gunna elders, both past and present, and also the other traditional custodians who live across Australia where our research is also conducted. The Registry of Senior Australians is a team that's dedicated to improving the quality of aging and aged care services. We are based here at SAMRI. There's about 30 researchers now that have been working in the registry for quite some time. And we were established in 2017 in response to some of the issues that happened in South Australia, actually, with the Oakden Aged Care Facility. And there was an investment from the state government to essentially develop a program of work that would be able to monitor individuals that enter the aged care sector. So the registry was established in 2017 by a collaboration of researchers, clinicians, aged care providers, and consumer advocacy organizations that are working together still to this day. And the mission was that we would use real-world evidence to achieve our vision of improving care and quality improvements for older people. We have as part of our program of work, developed not only a registry, but a data platform that recreates the registry nationally. But today I'm going to focus on just the work of the registry itself. The registry itself, every South Australian who has an aged care eligibility assessment is given the opportunity to opt out of ROSA. The introduction of ROSA is done by the aged care eligibility assessors throughout the state. And we have about 78,000 people registered in that cohort. And by going through this process of an opt-out process means that we have the ability to access identifiable information about these individuals. Once the individuals allow us to access their information, what we essentially get is all the information from their aged care assessments. And then we link that information to both their service records from the aged care sector, as well as a number of records from their healthcare sector. That is done through a very extensive data linkage process that involves both South Australia and the Australian Institute of Health and Welfare. Now, some of you may have heard me talking also about ROSA, the data platform. We refer to that as the historical data set, where we kind of recreated what ROSA, the registry, is in a national fashion. but in a completely de-identified way. So this de-identified data source has almost 4 million people now and includes the same data sets that the ROSA registry itself does, but also includes a lot other data sets to date now that were done for specific projects. The beauty of that data set is that we use it to do a lot of the development work that the registry then uses and a lot of the research projects that we do within my team. But the registry itself is the tool that we use to deliver information back to providers to do what the traditional registries do, which is to promote quality improvement and monitoring for a specific sector. And the work that I'm going to present today is related to that. So these data sources have been quite useful for a number of areas. So in addition to the research is also been used to provide information back to government and to providers and to the community in a number of different ways. The main thing that ROSA does is provide yearly reports to South Australian providers around the quality and safety of the experiences that the individuals that they're caring for had while in their care. This is essentially, like I said, what registries do well. We look at variation, we look at unwarranted variation and try to give information back to providers about benchmarks that might help them work towards improvement within their practices. We've done this in what we think is a very pragmatic and low burden way for providers. So we use existing data to do a lot of our reporting and monitoring, which I think is a really key piece of innovation that ROSA has done. We do this by using a standard set of metrics that we report on for the people that are both in residential aged care and in home care. So in aged care, there's about 1.5 million people nationally accessing any kind of services. About 250,000 people of these individuals go through residential care every year. About 350,000 go through long-term support at home services, that program. And when ROSA was set up, we developed a set of metrics that were determined to be important, feasible, usable for providers to act on when they were talking about populations in either a residential care setting or a home care setting. The set of measures that we use to report back to the residential care setting is here on the slide now. There used to be 12 of them. Last year, we reviewed our indicators and decided to retire 3 of them, and we added 2 new ones now. So now you're seeing the latest number of indicators that we're going to be reporting on from this year forward. We also, this year, have done a few other improvements to our reports. So in addition to give the variation that I'm going to show, we're also going to give more information about how it aligns with a lot of the changes that have happened to the aged care sector. So aligned with the new strengthened aged care standards. And we're also giving some information back on achievable benchmarks of care. For the home care sector, we report on 15 indicators. These are the indicators that we're going to be reporting as from 2026 onwards. And again, there were 3 indicators that were retired last year and 3 new ones that were added. Those are the green ones here. The home care quality indicators are very similar to the ones that we have in residential care, except the way that we talk about it is slightly different. We don't talk about performance of home care providers because we know that a lot of these indicators are actually a little bit outside of the responsibility or of aged care providers. They're actually much more related to just the health and well-being experiences of individuals from other settings as well. Before I go on, I just want to make a plug-in for the Australian Consortium for Aged Care Quality Indicator Repository. If you're interested in developing any sort of quality indicators and measures to monitor any sort of cohorts, if the focus is in older people, I encourage you to take a look at this website. There is 6,422 indicators that we have identified, reviewed, and tried to standardize the information about their attributes that I encourage you to look at it, because if you're ever thought of creating a new indicator, stop and look at the indicator repository first, because I bet somebody else has done it before. So I encourage you to look through it. But before I go in, this is, to continue now, the reports that we provide in South Australia every year are done three phases. There is a standard public report that we put out. That's what I'm showing you right now and there will be one for residential care and one for home care. Every facility that has more than 20 participants will receive these reports. And we also send in facility-specific reports. The home care participants is the same. There is about 120 services that deliver home care, long-term support at home in South Australia. About 97 of them do for more than 20 individuals, and those are able to receive their reports. The public reports are really high level, so they're just what you're seeing here. They're like a couple pages long, and they're available on our website, and I encourage you to look at it if you're interested. The provider reports are a lot more in-depth, and I'm going to show you a little bit about the report now. We give them information about how their provider, so the actual group, is doing, and then the facilities within or the services within are doing. This one page in the very beginning is using bullet plots to show how the facilities come in relationship to the averages, and then the extreme values, for example, are the distribution of the state. But then we also give them information about each one of their services or each one of their facilities. Early in the report, we give them information about their cohorts. This is important, especially in aged care, because there are facilities that specialize in caring for people that are, have a much higher prevalence of dementia or much more complex individuals, for example. And it's important for them to know how they compare to the entire cohort and then how they compare to Australia. And the Australia numbers that we have in this report are from our national historical data set. So already they have two benchmarks right off the bat in the beginning of these reports. Then we give them one page and each one of the indicators that describes why these things are being measured, how it aligns with the aged care standards that I mentioned to you before, which is their responsibility to monitor. How is it measured using these data? And then we give them a lot of different benchmarks about how they compare to facilities like them or providers like them of similar sizes and so on. This year, we also added the achievable benchmarks of care, which is based on analytical work we've done in our team and some of the research that we've done that try to estimate what the best performers actually are operating at. What level is the cohort that they're caring for experiencing these outcomes? So they're considered essentially data-driven benchmarks based on the best performance within the sector. And you can see here, the numbers are very small, but the achievable benchmarks for this chronic opioid use, for example, the best performing facilities are experiencing only a 12.6% prevalence, while this facility is operating at 15, 16, and the national estimate is actually over 20. So it's a really important measure to tell people that there are actually people caring for a substantial number of people that are doing really well. And I feel like that should be the benchmarks and not the averages. These indicators have been used quite extensively now. They were used in the Royal Commission in a lot of their reports. So the Royal Commission happened between the end of 2018 and beginning of 2021. And at that time, the National Quality Indicator Program nationally was not very, it was quite new and evolving. So this ended up being one of the main core metrics that were used to examine quality and safety and care nationally. They have now also, in the work that we've done, informed the national programs. In particular, there is a National Quality Indicator Program that's being developed for the Support at Home program that we have been involved in piloting and developing in the last few years. Also, these indicators have become quite a standard way of looking at the outcomes of individuals in these sectors, and not just by our team, but other teams. And I think that adds also a really nice way of looking at we're speaking the same language. We're using similar metrics now to monitor this cohort of people, which before these indicators, I don't think they existed nationally. So I'm almost at the end of my talk, but I'll leave you with what we're working on it next. So once you have a very robust program of quality and safety monitoring for a population, which is very useful to help providers improve their practices, to help, promote accountability, to help promote transparency, which is all the things that I think the ROSA OMS program does. What we should really be using this information for, though, is to try to predict and prevent future events. And we all know that there's an enormous amount of information gets collected on these individuals at the time of transitioning into aged care, be it residential care or home care. And there's a real opportunity for us to identify the people that are at a higher risk of having these events prior to the entry of these events. And I think that this is the other thing that ROSA can contribute to. So over the last few years, we have developed now over 11 different risk calculators for the metrics that I showed you before. At the time, in particular, of entry into residential care. There's 70,000 people that are entering into care every year. And based on our development of these risk prediction models, we've been able to identify the likelihood of these individuals experiencing that in quite robust models. And we're working towards developing a risk prediction model, an aggregate prediction model for all of the events in one place. And that's almost finished now. So you're just seeing the introduction of it all. So the slide right now that I'm showing you are all the predictions that we already have finalized. And this is an example of what it could look like if this still existed. And it's not for the lack of data or the lack of or feasibility, that it's absolutely feasible to do this. The only limitation and why this, I don't think, might be implemented in the short term is the governance restrictions around all this information living in the same place and us implementing such models. But this is what we've been working towards with using the ROSA data. And I just want to acknowledge everybody that makes this possible, including the South Australians that allow us to use their information to do this work, and all of the organizations that fund us, and also the ROSA team who makes all this happen.
Maria, that was really fascinating, and it's nice to see it all coming together. Thanks for the invitation to come along and talk today. I'm going to talk about the ANZICS Core Registry, and predominantly ANZICS Core has a suite of registries. The main one I'm going to talk about today is the Adult Patient Database, which collects data on the majority of ICU admissions across both Australia and New Zealand. See if we can get that. There we go. First of all, my affiliations, I have no conflicts of interest to declare, and I will add to both Maria and Lisa's acknowledgement of country. In fact, I've spent the last decade in Mabantua on the lands of the Aranda people, where I've been raising my children. I've only recently come to the lands of the Ghana people in Tanzania. There are 5 broad areas I'm going to quickly touch on today. I'm going to talk about benchmarking outcomes, and excuse the pun, it's the core activity of the registry. And Maria's already very eloquently described the process by which registries can be used to do a lot of that benchmarking. But I want to expand on that today, because while registries are really useful for benchmarking outcomes and benchmarking resource use, they can be leveraged to do a whole host of other things. And I want to spend perhaps 15 of the 20 minutes, perhaps a little bit less, talking about what those other things are that value add to registry use. But first of all, I need to put in place some idea of how the registry works. And this slide looks complicated. We're going to step through it really quickly because it's important you understand how the data is collected. Because what the APD does is collect individual patient data. So it's heavily reliant on individual ICUs and the people within those signing up to a commitment to collect the data and then submit it. So if we start on the left-hand side of this slide, you can see the picture of an ICU. That's where it all starts. Patients are admitted to an ICU, their data is collected, and for the most part uploaded to a cloud system that's called Comet. From there, units can still download their own patient identifiable data set. But from that repository, the data is de-identified and moved across into the adult patient database or one of the other registries. For both the paediatric and the adults, there is a PROMS system, and I'm going to talk a little bit about that sort of loops back into the registry. We also now have a biannual linkage with the National Death Index, so we can now obtain long-term mortality outcomes, and together with the PROMS data, that should allow us to get a really much more nuanced, granular idea of what's happening to people after their critical illness. It's at that point that all the data is aggregated, the reporting and benchmarking is undertaken. Most people will be familiar with the funnel plots. We'll have a close look at that in the next couple of slides. And all of that's fed back to the individual units to complete that quality assurance cycle that Maria's also talked about. One of the byproducts, though, of having such a huge repository of data is that it provides a great opportunity to undertake some epidemiological research. And I'm going to touch on some of that shortly. What that allows us to do is to create a snapshot at any point in time of what ICU services look like across both Australia and New Zealand. And this is important. It gives us an idea of resource use. It also highlights areas of inequity. Now, I wouldn't expect you to do the maths off the top of your head here, but you can see from even within Australia, there is a marked variation in ICU resourcing. It's about 6 beds per 100,000 head of population in Western Australia, nearly all of which is clustered in the southwestern corner, compared to, for example, New South Wales, who is approaching 10 ICU beds per 100,000. And within Australia, we're still doing much better than our colleagues across the ditch, where in New Zealand, they're approaching 5 beds per 100,000 population. And given ICU is such an expensive intervention, the data also allows us to have a really good look at what the outcomes from those are and what we're actually doing within the units. Let's talk about the benchmarking. Most of you will be familiar with these funnel plots. We got a little bit excited just before this meeting started because you put up a picture of a funnel plot and all the data nerds start dribbling and getting excited. But the funnel plot, really all the funnel plot does is describe your performance relative to your peers, but standardised for both things like illness acuity, age, chronic disease profile, using what's called a standardised mortality ratio. Now, the standardised mortality ratio is simply the number of observed deaths divided by the number of expected deaths. So if the number of deaths in your hospital matches what you predict, your SMR is 1. So you should see units clustering around 1. And when units are outside of that 99% confidence interval, it suggests that there's a problem. It might be statistical chance, but it might not be, and that's a good reason to start looking at what that problem might be. And ANZICS has developed over the last 15 years a reasonably structured approach to this. The units are identified, they're notified, we start going through a process of looking at their data in considerable depth. And there's an evidence base on which this is undertaken. It's loosely described as Muhammad's triangle, Muhammad's pyramid rather. It's based on some of the work that was done around the observation that Harold Shipman's murders could in fact have been identified earlier if this was being undertaken in a structured fashion. But what we find mostly is that outlier status is related to the quality of the data. Then the next most likely contributor is the case mix, and after that, resources and processes of care. For some pyramids, the clinician would be at the top of that, individual clinicians, but because ICU is such a team sport, we omit individual clinician stuff. What happens to outliers? Most of them come back within the plot reasonably quickly. And this graph simply plots the proportion of units that are back into the funnel plot and the reporting period. And about half of them are back in the funnel plot within 6 months, 2 reporting periods. And the vast majority are certainly back in within 2 years. But it's creates a whole lot of internal angst with clinicians. who are in an intensive care that has a higher mortality than predicted, you wonder what you are doing. It's also true that mortality is falling over time. This is our own data plotting mortality since data was first collected in the 1990s. And you can see, apart from the very end of it, where we've got a sort of a COVID-related phenomenon, the mortality's gone up, mortality has increasingly fallen. And that is in part attributed to advancing technology, but in part also attributed to this outlier process where things are reported back to units and changes made. That's the benchmarking stuff. Let me quickly go through the way that some of the registry data can be leveraged for further good over and above the outlier process. And I'm going to take you through a story here. This is a 10-year journey that a group of researchers took in thinking about cardiac arrest. The question was raised, well, once you've had your cardiac arrest, there's going to be some tissue which dies as a result of hypoxia, but there's going to be this penumbra around that ischemic tissue, which if we can increase blood flow to and increase oxygen delivery to and increase glucose delivery to, maybe we can improve outcomes. And one way to increase blood flow is to vasodilate vessels, and carbon dioxide is one of the things that causes vasodilation. So the question was put to the registry, well, let's look at the CO2 in the first 24 hours of these for these patients and see what happens. And it's an observational study, but it's association. But sure enough, they found that there was, if you had a slightly higher CO2 in the first 24 hours following a cardiac arrest, it did seem to be associated with an increased likelihood of going home. That provides the evidence base then to start doing some smaller trials, to put your funding request in for your large multi-centre international trial. And if you're lucky and it all comes together, your big publication is something like New England Journal of Medicine. And this is a journey that this group of researchers took over a decade, but it all leveraged in the first instance that observation based on physiological plausibility and generation of data that allowed the funding request to go in. In fact, it's a negative study, and in fact, CO2 doesn't change outcomes much for cardiac arrest, is somewhat academic in this. We can also use what's there to look at how we are responding as clinicians to changes in the evidence base. And again, I'm going to take you through a slightly ugly story in critical care. Around the turn of the century, there were 2 studies published in the New England Journal of Medicine that in retrospect actually had quite significant methodological flaws, but seemed to suggest that if you cooled survivors of an out-of-hospital cardiac arrest to 33 degrees Celsius, there was an improved mortality outcome. It's an awful process. You need to paralyse people, deeply sedate them. It takes them days to weeks to wake up from all the sedation you need to provide. And we were all very reassured when about 2012 and 2013, a further study came out which suggested that maybe it's not the cooling that is the big thing that makes a difference, but it's the avoidance of fever. This provided an opportunity then to look at how quickly we are translating these sorts of changes in the evidence base into clinical practice. And this elegant paper that came out a few years ago really neatly shows that sudden change. This just plots temperature along the y-axis and then time along the x-axis. Where you see that change in the shading is the month either side of the TTM trial coming out. You can see almost overnight, Australian and New Zealand ICUs abandoned the idea of therapeutic hypothermia. So it's a really neat way of demonstrating that the translation of clinical research into clinical practice. You can also use it for informing public policy. In this instance, what we did was link APD data with socioeconomic data from the ABS using their socioeconomic indices. In this case, it's ERSAD, the Index of Relative Socioeconomic Advantage and Disadvantage, and looking at the proportion of Aboriginal and Torres Strait Islander patients admitted to ICU and where they were placed on on the USAD decile. And that's the pictographic to the bottom left of that. The Aboriginal and Torres Strait Islanders in red, non-Indigenous in blue. You can see the Aboriginal and Torres Strait Islanders are vastly overrepresented in that lowest socioeconomic decile, and that has a public health impact. It also flows through to the most likely reasons to be admitted to ICU, which is the graph on the right, with Aboriginal and Torres Strait Islanders far more likely to be admitted to ICU for sepsis and following trauma, both of which are amenable to public health interventions. So there's a public health policy, public health message there to be looked at. Further, on a different note, this is a really nice piece of work that came out of our Victorian colleagues. They looked at ICU and hospital mortality outcomes, but against the proportion of ICU nurses who held advanced critical care qualifications. What you can see along the x-axis there is the proportion of nurses who hold that qualification, risk of death along the y-axis, and there's a very clear inflection point somewhere around that 70 or 75% mark, which would seem to suggest that if your nursing staff are upskilled and highly qualified, there is a mortality benefit. And this only reinforces what most doctors in ICU know quietly, but won't really admit, is that it's not the medical staff that make the big difference in ICU, it's the nursing staff. But this informs a wider discussion around ensuring that our nursing colleagues are appropriately upskilled in order to improve patient outcome. And that's, after all, what we're all here to do. In the last couple of minutes, I want to talk about where things are heading in the future. I mentioned that the registry is now linked to the National Death Index. That allows us to look at mortality outcomes after people have left hospital. And this is really important. We can produce survivors of ICU, we can produce survivors of hospital, but what happens if they're dying within weeks or months of leaving hospital? That's important to understand. And I think as a craft group, intensivists tend to be probably amongst the most pessimistic, and we've been reassured that the longer term survival for most patients is actually better than we think it's going to be. But it also allows us to look at various cohorts and subgroups to understand what's happening further. We also know that survival's not everything, and sometimes surviving can actually be worse than not surviving. And that's where patient-reported outcomes are really important. And there's a huge spectrum of potential survivorship, from completely surviving and going back to exactly as you were beforehand to actually being much worse off than you were before your critical illness. And it's only patients that can tell us this. So we've just finished a large pilot project that demonstrates that using text messaging, we get about a 30% response rate to patient responses, and we're getting a much better understanding of what their functioning is like 3 months after their ICU admission. And that's going to be rolled out across both Australia and New Zealand as a business as usual activity in the next 12 or 18 months. So watch this space. Those two together, survivorship and then function, are going to provide a really powerful tool for us to have conversations with patients and families before embarking on what can be a pretty invasive and awful process in intensive care. I want to quickly talk about this project. This is something we're working on with Queensland University of Technology and their machine learning unit. We watch units, we report back on their SMRs, but it's all in retrospect. Imagine if we could take that retrospective data and use the trends that we're seeing over time to predict their next SMR. If there was a machine learning model that we could leverage to do that, we could potentially let units know that there is a problem before they exceed that 99% confidence interval. And that has a number of advantages. Firstly, it prevents a whole lot of internal angst and work looking at your data. But potentially, if there is really an issue inside that ICU, inside that hospital, it potentially saves lives. And it turns out that we probably can do that using retrospective data to predict where things are going in the future. And our hope would be, and it's still early days, that what we could do is produce to units 3 months in advance some sort of warning signal that there is a possibility that they're going to fall outside the funnel plot, and to start looking at what they're doing inside the unit. And if it's a data quality issue, that's an easy fix, but if it's something else, you can start looking at it. Finally, ICUs actually form a very small part of the overall trajectory and journey that patients go on. And it's all about both data linkage, but also acknowledging that there is a wider journey. This is a piece of work that we did in Central Australia, looking at the impact of sepsis-acquired acute kidney injury on the probability that people would go on to either die or become dialysis dependent in the next 5 years. And what it clearly showed is that a single episode of sepsis-induced acute kidney injury in the ICU had a 5-fold risk of progressing to death or dialysis dependence in the next 5 years. That's a very unique population. There's high rates of CKD5D there anyway. But just imagine if we could put in place something that optimised sugar control, blood pressure control. They saw a nephrologist regularly. If we could save one person going on to dialysis or delay their dialysis for 6 to 12 months, that would be a huge outcome for that population. So I hope in 20 minutes, I've very quickly given you an idea of the role of the registry in terms of its benchmarking, but also the ways it can be leveraged to produce some wider goods and to value add to what we do as healthcare professionals, because ultimately, as I said, what we're all seeking to do is to improve patient outcomes, and the way to do that is by leveraging data. As an aside and a quick plug, there is an opportunity to have a play around with some of this data. If anybody is interested, there is a datathon associated with the Paediatric Intensive Care Conference in Melbourne in September or October. The datathon is free, and if you're interested and if you can get to that QR code that's there, please register your interest. They're usually a lot of fun. At that point, I'll hand back to Lisa and we can try and answer any questions. Thanks very much for your time.
Excellent. Thank you both for your wonderful presentations.